Hello, I'm Scott Tunison, a teaching and learning specialist in the faculty development in the College of Medicine, as well as a member of the MPAS faculty at the University of Saskatchewan. Today's episode of the Saskatchewan Physician Assistant Podcast, we are exploring the question, how do physicians and physician assistants work together? I have four guests joining me today. Here with me in the studio is Dr. Paul Olszynski, Professor of Emergency Medicine and Director of Simulation and Clinical Ultrasonography at the University of Saskatchewan. Dr. Kathy McLean is a family physician and medical education leader with over 30 years of experience. She's currently Director of Faculty Development at the University of Saskatchewan's College of Medicine. Dr. Warren Latham is the Corporate Chief of Orthopedics at Scarborough Health Network and the lead surgeon of their foot and ankle program. He's also president of the Canadian Orthopedic Foot and Ankle Society. And Arthi Murtu is an experienced physician assistant working in emergency medicine and orthopedic surgery at Scarborough Health Network. She also serves as academic coordinator in the University of Toronto's PA program, supporting curriculum development and student success while sitting on key academic committees. Thanks all of you for joining me today. Physician assistants are a newly regulated profession in our province. Today, our panel will discuss their experiences working with and as physician assistants in their areas of specialty. We will also delve into how physicians and PAs work together, covering topics like role definition, team dynamics, workflow, and supervision. First off, let's start by getting a brief overview from our physicians about their previous and current working experience when working with physician assistants, particularly in the context of team-based care in their areas of specialty. I'd like to open it as a panel discussion to all three of you to give us your opinions and experiences in this regard.
We've incorporated physician assistants and nurse practitioners both into our clinical sites. We have 3 hospital sites across the Scarborough Health Network. And within our orthopedic division, we've siloed our surgery at each site, joint arthroplasty at our Birchmount site, sports reconstruction primarily at our Centenary site, and spine and trauma at our general site. And within each one of those siloed sites, we have physician assistants working directly with our physician team. They're involved in care on the inpatient units. They're involved in the emergency department and seeing new consultations. They're involved in the clinic and seeing patients alongside our physician leaders. They've incorporated now over the last 5 years directly into our team on an everyday basis. They assist in the operating room. They actually are become leaders in our hospital in lots of different respects when it comes to organizational needs, including quality improvement projects. We've had to create certain pathways to be able to manage between 3 sites with all of our clinical volumes. And Arthi can tell you and attest to the fact that we had to figure out how to manage that flow of patients, and that's all done through our physician assistant program as part of our orthopedic navigation quality improvement program. There's always a learning curve with instituting new clinical roles at our hospital as well. Our emergency department is intimately associated with physician assistants. And in fact, Arthi actually came to us from the emergency department. But all these things take time, and it is an element of culture that's required around including these clinical roles into a surgical program. But now I can't imagine how we would actually function without it. Because it's just become such a mainstream part of our day-to-day activities.
Thank you very much. Dr. McLean.
I think the emphasis on team-based care and the role that PAs can have working alongside physicians is really critical. And that's the experience that I've had sort of spanning probably altogether almost 20 years now, where I've had some opportunity to work with PAs, but mostly been involved in developing models that include physician assistants in team-based care. So that would include work done in Alberta, where we were establishing a patient's medical home approach and looking at the types of team-based members that we could have integrated on the team that would help provide care, and also experience in Nova Scotia, both from direct experience working with PAs who had been in the military, and this was early days when they were retiring from the military and looking for civilian positions, and that was an amazing experience to see what they were capable of and how that model worked in the military and how it worked primarily with our emergency room physicians in the Halifax area. When PAs first started being deployed in some of the local jails, covering overnight shifts, which dramatically decreased the number of visits to the emergency department, and was, I think, a really brilliant solution, both for the staff in the prison system, but also for the staff in the emergency areas in that particular system. But we also looked at just the full scope of practice and how much PAs could do, and the excellent communication and collaboration that occurred between physicians and PAs when working in systems like that. And it really, I think, contributed to basically sharing the load and making things a whole lot more feasible, and took a lot of sort of stress related to sort of the burden of care directly off of physicians, because they had such reliable partners that could help in the delivery of the care that was needed.
Thank you very much. And Dr. Olszynski.
Yeah, so as an emergency physician, team-based care is kind of the norm for us. We rely on our nursing colleagues, our respiratory therapists, and it just so happens, I think one of the reasons I'm here is just several years back, a colleague reached out and said, hey, I've got a friend who's studying in the U of T PA program. Could they come and do a month with you here in Saskatoon? And I said yes, and I got the opportunity to work with them as a shift supervisor, but basically really very quickly realized that I kind of got this, this bonus month basically where I had someone working with me and really helping as a team us to deliver kind of what I thought was significantly better care, because we were able to at times work on the same problem together, but at other times also we were able to split off in different directions and kind of be in two places at once when we needed to. And I think that ability to create a team that can pivot and can react that way to different things, I think is really where, going back to what Kathy just said, you start to realize that you can distribute the workload, you can give the patients the attention they need, and then you can also be all working to your scope and to your capabilities, and then feeling, I think, that at the end of the day, it's a better day.
Great, thank you very much. And I'd like to open it up as well to Arthi. From your perspective as a PA, what does it look like, and how do you feel that you can contribute in the context of that team-based care?
I think the PA role is unique because it's versatile, and working in both emergency medicine and orthopedics, I think that wherever there's a need, a PA can try to fill that gap. So in Emerge, just for some context, I could work with like 6 to 8 physicians in a 10-hour shift. And as Dr. Olszynski said, I would extend their services. So I could walk into a shift and just pick up a patient, do the history and physical, and discuss the case with the physician. Or if they're busy, let's say in recess, then I could order the investigations and treatment options, because with time you build that relationship to know what that physician's preference is, and you build that that confidence so that the physician can trust your decision making as well. And this is one of the ways that a PA could help in the department. But we also do callbacks. We also help with other QI initiatives. And one of those initiatives in Emerge was a fast track area designated for those CTAS 3 to 5 cases, and helping offload that so that the physicians can focus on more acute and major patients. So CTAS 1 and 2. And then I like orthosurgery, is, as Dr. Latham mentioned, the Ortho Navigator is a unique opportunity where as a PA, with my clinical background, I can triage the referrals. So any referrals that come from the emergency department, which sometimes I would work in Emerge and then send a referral in and then triage the same referral, or from the community primary care providers, it would go through the navigator to streamline the process and also load level the clinics across the 3 sites. And this way, the patients are seen by the appropriate orthopedic surgeon, so based on their subspecialty. So we have upper extremity specialists. Dr. Latham specializes in foot and ankle. So the patient's seeing the appropriate provider and based on their urgency, so we can expedite surgical management and a few quality improvement aspects in that regard. So I think to answer your question, wherever there's a need in the system or in the hospital setting, I think a PA can address that gap as needed by serving as an extension of the physician.
Thank you very much. And something that you mentioned made me wonder, are there specific areas of medicine where PAs are better suited than others? And that would be open to any of the 4 of you.
Wherever you can find a physician, you can find a PA. I think the sky's the horizon in that regard, but there are obviously more specialties or common specialties that PAs are often found. So primary care, emergency medicine, as mentioned, is a team-based environment, so it's great. And even in orthopedics, whether in the OR, fracture clinic, working with one physician, or inpatient unit managing multiple surgeons, patients, anything's really possible.
Thank you. How about the physicians on the panel?
I would say that, based on the amount of work that is now necessary within, your clinical practice, obviously I'm biased towards surgery. My opinions come from surgery, but the amount of things that physicians are now asked to do, from not only their clinical practice, seeing patients, writing their notes, doing their surgeries, doing rounds, teaching residents, fellows, and med students, doing clinical research, doing quality improvement projects, being a leader at the hospital within, a leadership structure. Like, without, support, I'm not sure how physicians continue to perform those tasks at high levels. And I think that's the really, to me, where I see the benefit of physician assistants is when I'm trying to accomplish all those things in a day, I have somebody with me who can help, shoulder that burden and make me a more effective teacher, surgeon, communicator, collaborator, professor, right? I think that's without that support, everything is just a little bit lessened.
Thank you very much.
I think that emphasis on having that support, especially when you're trying to function in different roles, it is an excellent one. But I do think that sometimes the value of having PAs work in primary care is not necessarily recognized. So even though they can play a really important role in hospital medicine and working with specialists, I think there is a really critical role for them to be partners with family physicians delivering primary care in the community. And they can play a very similar role for support with the multiple hats that primary care physicians are also having to wear. And it does allow you to get through your day and to feel like you're doing a good job because you have that added support, that extra set of hands that can dive in and get the work done.
Thank you. How about you, Paul?
Yeah, I mean, I think those points really ring true. I guess the other piece I'll just add to is just the fact that we're facing scarcity. Like we don't have the workforce to meet the needs of our populations. That's certainly the case in emergency medicine throughout the country. Huge shortages forecasted for many years to come. So aside from all those other really great things, which I think are wonderful to hear, but I think there's a need. Like this is at a stage now where we at least from my perspective, what's going on in Saskatoon in our departments, we have a desperate need to meet the demands, and we're not meeting them right now. We have patients waiting 9-10 hours to be seen, and we know that we can't fill that and we can't meet that need with our current system. So we do need providers at different levels who can work together to meet that demand.
Very good. Thank you very much for all your input on all of those things. Research literature suggests that including PAs as part of a physician-led team-based healthcare team yields several key benefits. Many of you have alluded to some of them, things like improved patient access to services, enhanced quality of patient care, reduced burden on primary care physicians, expanded healthcare services in underserved areas, and all kinds of other benefits. What I'm curious about is which of those, or others perhaps, of these purported benefits have you actually witnessed when you're working with a PA, or for that matter, for Arthi when she's working as a PA? Maybe we'll start with you, Arthi.
So one of the major things I noticed in the emergency department is wait time. So that fast track initiative I mentioned earlier, but also generally when you have that added team member, the wait times to see a patient and get the appropriate care is way shorter. And I think Dr. Latham can speak to this more, but the introduction of a PA at one of our sites where we do the joint surgeries, we've noticed more throughput because the PA is actively there helping with discharge planning and monitoring that patient. So from a surgical standpoint, that is also one of the benefits that we've seen with adding a PA. I don't want to take all the points, so I will hand it over to Dr. Latham, maybe if you want to elaborate more on that.
Sure. I mean, I think all those are valid points. I think the biggest thing that we're trying to think about is how do we do more work in the same amount of time, and without, support and extenders of physicians that are sort of intimately tied to the team. I don't know how we continue to do that. And, whether it's wait times for, elective surgery, or it's wait times for emergency surgery, or it's wait times in the emergency department, it's still a wait. Right. And what we're trying to figure out is how to create the most efficient system possible with the resources that we have. And so the way for us to do that is to allocate more resources. And that was what physician assistants are. They're critical resources to be able to try and do the things that we need to do in the most efficient way possible.
Thank you very much. Dr. McLean.
I was reminded of a plastic surgeon who did an MBA at St. Mary's not long after I completed mine, who actually did a study looking at the role of PAs on a plastic surgery service, and then was able to implement that, I think in Manitoba, if I recall, afterwards. But just in terms of the increased efficiency and use of the OR, that ended up being a really critical argument for having physician extenders in roles like that. The only other thing I don't think this was on your list, Scott, but I remember working with the PAs from the military who had retired. And one of the things I have to say was how much I learned from them. So I think whenever you get other team members involved in the care of the patient, your overall learning and engagement, I think, is enhanced. I think they bring a really important perspective. I think your brain just opens up to even being able to learn something yourself, because you're not in that, I got to get her done, focused kind of mode. And I think we all need to be in environments where we feel like we've got the space to think and to, learn new things and to work with people, so we can engage in all kinds of areas like quality improvement and things like that. So that was one of my experiences.
Thank you very much. And Paul, how about you?
Well, I really liked what Arthi said earlier about being kind of like a pluripotent cell, a physician assistant can really pivot. And so I remember during our shifts, whether we were And this was in the days before some of the new anticoagulation medication. So we'd be starting a patient on a new anticoagulant, and it was pretty complex. They had to get loaded with the dosing, and it was a perfect example where I could be like, okay, you're going to do the teaching about the meds, yeah, and then okay, we'll meet again afterwards, and that opportunity then for the PA to go and really spend time with that patient and really make sure they understand their instructions on discharge, what they're going to be dealing with, and then go and perform a point-of-care ultrasound on a patient, confirm an intrauterine pregnancy, reassure the family, send them on their way with, So I think we can talk about it at the system level, but I think the thing, and again, that cognitive space that opens up is because we know now that our patients are actually getting that care that we would want to be able to offer them if we weren't being pulled in 5 directions at this, right? So it really, I think there's that consistency here, whether we're talking about extending and increasing the capacity of a team versus a single individual. And I think that's the key piece there for sure.
If I may just jump in, I know we talked a lot about quality patient care, but we also, I think, adding a PA to the team and sharing that cognitive load or reducing the cognitive load by having another team member. I think we noticed this in Emerge, especially during COVID times, the physician burnout, and having that additional PA there to help with procedures or whatever the need is really helps with the satisfaction the physician gets from the care provided and all providers on the team, but also the burnout by sharing that workload. So also something important to consider.
That's for sure. Thank you very much for that. Then, and that actually brings me to the next point I was going to make, which is have any of you encountered any challenges when incorporating a PA into practice? And if you did, how did you overcome them?
Yeah, we've certainly had challenges. I think it comes from culture, right? Like if you are going to make a change like this, you have to understand that there will be some resistance, there will be some hurdles, there will be some setbacks. I think it comes from creating a clear direction from the beginning about what is, and clear expectations, and then reinforcing those expectations with time and making sure that people understand what the overall goal is. And I think most people, when it comes to system change, if they understand why it's happening, I think that they tend to be more appreciative and understanding. But, when people have worked a certain way for 30 or 40 years, when they've worked for 30 or 40 years in a certain way, it may be challenging, to have them change the way that they work, right? And so I think you really have to look at it from a systems perspective about how do you make that change. And in general, all of those hurdles can be overcome. But a lot of that is just about, consistent communication all the time and making sure those expectations are set from the beginning.
Thank you very much. How about you, Paul?
Yeah, I think understanding that there's going to be a time, it's going to take time to get to where we want to be. So that, becoming familiar with a new member of the team, becoming familiar with their skill set, and I think goes back again to making sure that everyone knows kind of which direction we're going. And I'm a big fan. I think this is a term coined from MIT, but compass over maps, right? So we've got a direction, and how we're going to get there and exactly what that's going to look like, that's going to evolve in time. And we're going to have a great plan, and then some crisis is going to happen or something, and we're going to have to pivot. But I just to echo, I think those comments about we're going to want to early on, we have to have that mindset that this is a process that's going to be developing, and that it is not, at month 1, 2, and 3 isn't what it's going to be. It's, at a year, we're going to actually start to see really what this is really going to, the potential is starting to actually play out. So I think that's an important piece of it.
Definitely, thank you. Kathy?
I would just echo, I think, some of the themes. This will be a steep learning curve. And it will feel maybe a little more overwhelming at first because it's that one more thing in what's already a stressful situation, sort of juggling the number of balls we have in the air. But I also think there's great reward with this. And I think one of the key strategies has to be communication so that people actually understand what the role of the PA is going to be, and start to really appreciate the really important collaborative relationship that exists between the physician and the PA, and actually learning how to develop that trust. Um, but I think those are important skills that we need to learn so we can interact with other team members effectively as well. And so as our system transitions to more of a team-based delivery of care, those are skills that I think will really serve us well as we move forward.
Thank you very much. Arthi, have you, from your perspective, what challenges have you encountered as you were incorporated into a team, and how did you overcome them?
I always joke about this. So from PA school, we're always trained to have an elevator pitch for what's a PA. Because usually when you say you're a physician assistant, the next question is, what's a PA? So, and all that to say, like 5 years later, or I guess 7 years since I started PA school, it's almost it's rewarding to see that that question doesn't come up as often, because either they've worked with a PA or encountered a PA as a patient or heard of a PA somehow. So all that to say, I think that when you're adding a new member, or whether it's a new project like that Ortho Navigator project we mentioned earlier, like change management can be challenging, and communication, as mentioned earlier, is very important in that. So frequent check-ins, asking for feedback. And I think when you are introducing someone to the team, emphasizing that it's a common goal that you're all working towards. It's not specifically on that individual that you're adding to the team, but it's everyone working towards improving patient care, or reducing wait times, or sharing that workload, or whatever it may be. And I think that when it's more of a team-based approach to this new member, instead of focusing on that individual, it does change the perspective and the approach, and it's a bit more, it's more of a positive effect.
Great, thank you very much. I'm going to shift gears now a little bit, because we're lucky to have a physician PA dyad on our panel today, and I want to focus on them for just a little bit, if that's okay. And it would be great to start with some basic information, things like, how long have you worked together?
I think we're the dyad. We've worked together.
3.5. Yeah. 3.5, 4 years. Yes.
4 years. Yeah. 4
Yeah.
years.
What does your day-to-day workflow look like? If there is a such thing as a typical day, what would that be?
So as an ortho PA, my day-to-day, depending on the setting. So when I did inpatient, it could be pretty much, if an emerge consult came in, I would be in the emerge seeing the patient. And maybe if the orthopedic surgeon, like Dr. Latham, is working in the OR, then I would see that consult and then discuss with them later. If he is running fracture clinic, then I will be by his side during that clinic, seeing patients, reviewing with him, and managing the clinic in that regard. If it is in the OR, then you would assist. So in the OR and assisting with the surgery, and then lastly, like inpatient, again, it could be multiple surgeons, patients on the floor, on the unit, and you would be rounding on them every day, making sure you review their blood work, seeing how the patient's doing, discharge planning, and working with the allied healthcare members on the floor. So physiotherapists, occupational therapists, social workers, pharmacists, and many more, nursing staff, and making sure that you're taking care of the patients as an extension of the orthopedic surgeon.
Yeah, I think that's a great summary. And that's really sort of a typical generalized overview of what our physician assistants do on a daily basis. I would include that we also, Arthi in particular, and our actual day is based in the quality improvement realm, looking at changes in process and system changes in the hospital. So Arthi actually spends a lot of her day combing through information, talking to people who work in the hospital about what they actually do in the hospital. For instance, now we're trying to completely revamp the rehabilitation process for our total joint patients that is outdated, since we now do 60 to 70% of our joints as day surgery. We haven't changed it since we started doing that. And so we have a lot of confusion amongst all of our allied health team about how this process works. So we're currently at the beginning of that quality improvement initiative. So our day-to-day is actually focused on sort of those exercises. But I think, she gave a very wholesome description of what our other PAs do on a daily basis. Um, and I think that, whenever we're talking about this kind of clinical extension, and I think somebody else said it already, I think it's a great way to think about it. Like these PAs can fill those spaces. And that's really what we're talking about is, we have 3 sites that have to work in unison. We needed to create a way to make sure that our patients are flowing between sites. And our physician navigator, through the resource that we were given through our surgical department, or that we advocated for, we were never given it, we advocated for, was a perfect way to do that, right? And here we are 2 years later, and we're extremely efficient in the way that we manage the flow of these patients. We're extremely efficient with our clinic utilization. We're extremely efficient with our trauma room utilization because of that process. So I think, that filling of gaps is it's the big take-home message for me. That's where, PAs can provide a super valuable resource.
Thank you very much. Now, Dr. Latham, I'm curious, what made you decide either to hire a PA or to advocate to get one? I'm not sure exactly what the hiring structure looks like, but why did you want one in the first place?
Well, I want to be perfectly frank, and I think most people know that orthopedic surgeons tend to have an aversion to things like charting. And things like ordering the correct medication, rounding. Orthopedic surgeons are focused on other things. They're focused on the technical aspects of their job and being excellent at that. And our group is a well-rounded group that is very full of excellent surgeons. But I think that there's always room for improvement. And I think as a chief of in the senior leadership team of the hospital, I look at those metrics about how we're doing in terms of our length of stay, our medical reconciliation record, our overall patient satisfaction, our mortality rates, and look and say, how can we improve those numbers? How can we make the Scarborough Hospital something to be proud of, and something that people look at as a model for good care? And so those are kind of lofty goals, right? But that's how I think about it. And to me, that came about by helping managing deficiencies, right? And specifically areas of weakness. How do you address a weakness? Well, you work on it, right? You practice it. You figure out how to add resources to minimize it, right? And so to me, that's where the physician assistants came into play, because I couldn't hire another surgeon to do those tasks, right? I couldn't hire another surgeon to do those without providing more clinical resource for surgery. But I could, hire someone who is, more than capable and interested in those particular, avenues of care and those parts of the job, and, do them better, quite frankly, than surgeons. And I think there's some data now that certainly looks at, particularly for us, when we look at, where we were 4 years ago, we can see in our own data the amount of improvements and, all of those factors. And that's really how the decision was made. And quite honestly, when you make these kinds of decisions, you hire slowly but fire fast. And so when we hired our first PA a number of years ago, we got really lucky. She was excellent. She had a physiotherapy background, and she really changed our program immensely, and is still with us. And that really reinforced for us, like, this was a way that for us to elevate our program in all the ways I discussed.
How long did it take you to adapt to working with a PA?
Well, I mean, it took enough time that people had to sort of be comfortable, right? And so change management, everybody's different, right? And I think it was already mentioned, right? Like it's a circuitous pathway to get to an end goal, right? So lots of people, like especially the younger surgeons, did it very quickly and very easily because they were sort of much more malleable in terms of their workflow. Some of our older surgeons who had been in the hospital 30 or 40 years, they were a little bit more reticent about changing their workflow in a dynamic environment where they're already being asked to do so, right? So I think it was very different. I think that based on who you're particularly asking, it was very different. For me, it was pretty seamless. But I think you have to be cognizant of the fact that not everybody's going to be at that same pace.
That's fair. So looking back on the time and energy it took you to establish the work relationship you describe, in what ways were those investments worthwhile?
I don't think that I could do my job. I mean, it's worthwhile because I'm freed up to do so many more things. And and for instance, like just clinically to focus on the surgeries that I'm actually doing, that improves the quality that I'm providing, right? But I think as well, like to be able to do the things that we needed to do to integrate our department, our division within our department across 3 sites, I don't know how we could have done it without, physician extenders. I don't know. In fact, it was one of the primary asks of our group when performing these kinds of quality improvement projects. Like, we need physician extenders to be able to work at multiple sites. Like, how can we take call at one site, do a trauma room at another site, and our joint replacements at another site without that kind of support? And so, no, it was completely essential. We couldn't have done without it.
Thank you very much. Now, Arthi, did you require any additional training on top of PA school to do the work that you do in emergency medicine or orthopedics? And what did that look like, if you did?
In PA school, you're trained as generalists, so we're trained for family practice, I would say, for the most part. And when I started in Emerge, I had a group of senior PAs who were great. They oriented me. I think it was about a month where I would be working alongside them and had that additional support to ask questions, and they would show me the ropes about how things were done in the department. So that was a good orientation, but it was still a steep learning curve regardless, working in emergency medicine as my first job as a PA. So I would say it took about like 3 months to get comfortable. There were no additional training per se, was learning on the job. And then 6 months to get a bit more comfortable and somewhat autonomous. And again, I work with, I think, over 50 physicians. So every shift would be a new physician. Sometimes a few of them I would work with more often. So learning their kind of their style of practice, and again, building that trust to be able to be a bit more autonomous with time. So I would say I don't know if I'm like I would like to say I'm comfortable now, but I would say that like 6 months to a year for you to be comfortable going into a shift and being able to kind of be ready to see whatever walks through the door. In terms of ortho, again, a steep learning curve. So my story is, first year I worked in Emerge, and then an opportunity came up where the physician assistant that Dr. Latham mentioned was going on mat leave. So she was like, this might be a good opportunity. She was a classmate of mine. She's like, this might be a good opportunity considering your background in kinesiology. I was like, sure. Always been interested in ortho, so let me give this a try. And little did I know, second year in practice, another steep learning curve. And I would say surgery, again, is less covered in PA school. So you learned orthopedics, you learn musculoskeletal conditions, injuries, and whatnot, but the actual surgical management and a mix of internal medicine as well in terms of managing the patients on the ward. It was definitely a steep learning curve, and I had a group of surgeons who were supportive, were happy to answer my questions as needed, and again, working the different settings, so OR, clinic, the ward, and seeing consults in Emerge, which was different from working in Emerge and consulting orthopedic surgery. So it was all a steep learning curve, but again, with time you get a bit more comfortable. And I think the beauty of it is that you work in that dyad that you mentioned, and you work alongside the physician. So there's always that support and that opportunity to collaborate to provide the best care.
What drew you to the PA profession in the first place? What do you like most about being a PA?
Yeah, so I was a kinesiologist before, and I was interested in medicine to broaden my scope. But I wasn't entirely committed to that many years of schooling, and I also didn't want to stick to one specialty. So I was looking at options, and I came across the PA program at Manitoba, and it was like a Google search, and I was like, this can't be real. This profession can't be sounds too good to be true. And I knew that it was more established in the States, even considered going there. So I applied, but I decided to stay close to home, and I'm glad I did. So yeah, I like that it was 2 years, like the opportunity to practice medicine and the ability to work in multiple specialties, which I'm grateful I'm able to do so, working in both emerge and orthopedic surgery. And they say work-life balance is better, but again, working alongside and depending on your interests and the opportunities that come up. As a PA, I think that as long as you're happy with what you do, even if it's busy, it is worthwhile. And then the last point is financially. I know some people consider med school to be a big financial commitment. So for me, I wanted something that was in medicine, shorter schooling, less in terms of financially regards, and then also having that flexibility to work in multiple specialties.
Thank you very much. Now, I have one more question for you. What do you have any examples of how the fact that you are a PA and were in the healthcare team, examples of patient care getting better or improving, as opposed to maybe if you or another PA hadn't been there?
I think so. As a kid, I was passionate about counseling, and I think that as a physician assistant, I'm able to do that. So, Dr. Olszynski mentioned counseling for like discharge medications. Blood thinner is one of the discharge medications post-operatively, and counseling patients on that, spending that extra time to talk to them about their medications or answer their questions. In primary care, that may look like preventative health counseling and talking about lifestyle modifications. And emerge, that's providing the instructions as to when they should return to emerge and red flag symptoms to look out for. I think that that is an area that PAs excel in. And again, it frees up the time for physicians to also have that extra time to talk to their patients as well. So quality of care is definitely something that's helpful, whether it's preventative and educating the patients or answering their questions and making sure that they feel that they were well cared for.
Thank you very much. Now I'd like to open it back up to the whole team, to the whole panel. And we're going to wrap up with the final question. And the final question is, what benefits of having PAs as part of healthcare teams do you think we will realize here in Saskatchewan? And what advice do you have for us as we launch a new profession as well as a new training program here?
I think there'll be lots of benefits. We've heard improved access, improved care, prevention of burnout, sharing the load and having extenders that you can collaboratively provide better quality care. And freeing physicians up for many of the other roles that they are trying to juggle in a day, that might be leadership within the health authority or within the College of Medicine. It might be doing QI or research, and knowing at the same time that the patients are being well looked after is critical. In terms of the things that we need to do for the program, I'm hoping that we can tackle this with a really open mind and recognize that there are new skills that we also need to develop. And that includes those skills associated with being an effective team member and what that looks like, what the communication needs to look like when you're collaborating with a physician extender would be something I think we need to look at. And then Scott, you and I have had multiple conversations about what does it look like to have layered learners on your team when you've got a family medicine resident, a PA student, a medical student, maybe working on the same clinical service at the same time. How do you engage each of them in working together effectively? So I would see that as an important area for us to be focused on as well.
Great, thank you very much. How about you, Paul?
Yeah, I think those points were fantastic. I think, communication, this came up often, whether it's communication in your team or whether it's communicating more broadly with your community that you're working with. I do think that this is a great step, having these podcasts, having these opportunities for people to engage and start thinking and priming them for kind of what's coming, I think is really great. So I appreciate you guys inviting me, and I hope that we can, through our own connections and channels, get people to come and pay attention to this as it's coming our way. Because again, I think it is going to take some new skills, and there is going to be some work involved to get this going in the right direction. And so I think getting that communication out front is going to be really helpful and really important.
Thank you very much. Dr. Latham.
Just like to echo those sentiments. Thanks very much for inviting me. I would also just look at it in a different way. You're talking about like what are the potential benefits? Well, I would look at it another way and say, well, what's the downside? Like, what's the negative outcome? Like, it's, when you can provide care to someone with almost no negative outcome, I think you're really, doing a service for patients. And that's what I would say about physician's assistants. They're really, there's challenges for sure, but in the end of the day, you're going to see a positive result.
Thank you very much. And we're going to give you, Arthi, the last word.
I would echo everything that's been said so far. So communication, being open-minded. We talked about change management, and I would just add, I think feedback is very valuable. So asking them how they feel in terms of how things are going, but also that will help you address potential issues or even improve things. So I think that asking for feedback and that frequent check-in as you integrate physician assistants. And again, we've all mentioned team-based approach. So this is a new team member to ultimately work towards the common goal of improving patient care. So I think that there's no downside to that. And we talked about all the benefits. So thank you again and all the best.
Thank you very much. And thanks to all of you for joining me today on this podcast. In future episodes, we plan to explore topics like what our MPAS program will look like, how PAs are certified and licensed to practice here in Saskatchewan, and many more topics like that. In the meantime, we wish you all the best and look forward to connecting with you again during our next podcast. Thank you.